Hello, everyone. Thank you for taking the time to participate in this webinar. Obviously, with some of the great weather we've had lately, everyone's mind is shifting towards spring sports, and rightfully so. But we'd like to emphasize safety in all these endeavors, and that's what this talk will touch on. My name is Demetris Delos. I'm an orthopedic surgeon with the ONS Group. My practice focuses on shoulder, elbow, and knee conditions, and I'm a sports medicine specialist. So briefly, we'll touch upon the various sports that we encounter in the spring and some of the injuries that we often see with these sports. We'll touch upon specifically the shoulder, elbow, and knee conditions, and we'll go into a little bit of depth with that. And really the meat and potatoes of the talk is how do we prevent injury? And that's what we'll spend a lot of time on. So opening day was just last week, for instance, in baseball. What do we encounter in baseball? As you might expect, there's a lot of upper extremity injuries and conditions. The shoulder is very commonly affected. We see tendonitis involving the rotator cuff as well as the biceps tendon, and impingement syndrome, which is a condition where elevation of the arm can cause pain in the shoulder. We also see elbow injuries, including tendonitis on either side of the elbow. And the dreaded UCL injury, thankfully, is pretty rare. So that's the Tommy John ligament. When you hear about Tommy John surgery, that's what we're referring to. And in the pediatric patient, the pre-adolescent and the adolescent patient who's still growing, oftentimes what we're thinking about are overuse injuries and growth plate injuries. So golf is almost in full swing too. The Masters is coming up this week. What do we think about when we think about golf conditions? Elbow pain obviously is very common. So there's even a condition called golfer's elbow, which we'll touch upon. Although frankly, you might see more tennis elbow playing golf, especially in the lead arm, than you might see golfer's elbow. We do see shoulder conditions, and we also encounter, unfortunately, back pain. Thankfully, for most of these, obviously, they can be treated non-operatively. Lacrosse is also popular. We see a lot of muscle strains. We see some knee injuries involving sprains or contusions, which are bruises. Thankfully, ligament tears are pretty uncommon, although on occasion you will see an ACL injury. Ankle sprains are very common, and shin splints are something we also encounter in a lot of the land-based sports that involve a lot of running. So lacrosse, soccer, and also, of course, jogging. Those are all activities in which we have to keep an eye on overuse problems of the lower extremities. Running and jogging. Probably the most common thing we see is Patellofemoral Syndrome, which is basically a condition where the kneecap gets inflamed with the constant flexion and impact activity. And usually people will report pain in the front of the knee or sometimes even the back of the knee. We also see a fair amount of hip disorders, including groin pain, which can be due to a variety of things. It could just be a strain. It could be a labrum injury or even some arthritis. Ankle sprains are also pretty common in runners. And of course, you have to think about shin splints in people who report persistent pain in the lower leg, especially after running and sometimes during running. Soccer, of course, we see a lot of muscle strains, quadriceps, hamstring, calf, like a lot of these other sports. Some knee injuries, sprains, meniscus injuries, and ACL tears, unfortunately, can be somewhat common, especially in younger athletes. Ankle sprains and shin splints. As you might expect, tennis can lead to tennis elbow, although they can also experience golfer's elbow, shoulder pain, and muscle strains. So what are the most common things we see in the shoulder? Again, my practice focuses primarily on shoulder, elbow, and knee conditions, so that's what I'm going to focus on. And frankly, these are some of the more common things we see overall, so they can be beneficial to all of you in the audience. Shoulder bursitis and tendonitis is probably the overwhelming most common thing we see. And when we talk about tendonitis, we're talking about the rotator cuff as well as one of the bicep tendons called the long head biceps tendon. One of the other things we will see on occasion are labral injuries. In younger athletes with instability problems, oftentimes it's the front or back labrum. In older athletes or adults, oftentimes it can be the superior labrum or slap tears, as you might hear on occasion. Frozen shoulder is something that, frankly, we don't completely understand. We don't know why some people develop frozen shoulder, or as we call it, adhesive capsulitis. But what it leads to is increasing tightness in the shoulder, and it can be very painful. That's pretty common. Shoulder instability is when the ball moves more, basically the ball has more motion relative to the socket than it should otherwise, and that can lead to either subluxations, which are partial dislocations, or even frank dislocations where the ball comes completely off the socket. So if we think about the shoulder as a ball and socket, which it is, it's a relatively large ball on a relatively small flat socket, and it's inherently unstable. And if the ball shifts slightly against the socket but doesn't go completely off the socket, that's a subluxation. If it goes completely out of the socket, that's a dislocation. That's pretty common in younger athletes, teenage and college level athletes. And shoulder arthritis is something we'll see more in our adult patients. Now, what is it that sort of will give us a clue that something is going on? We call these signs or symptoms. And when we think about it, probably the most common thing, of course, is pain. That's the most common reason you'll come and see someone like me. But we want to be a little bit more precise. We want to localize that pain. If the pain is in the front of the shoulder, oftentimes it can be the biceps tendon. If it's along the side of the shoulder, it's usually the rotator cuff or the rotator cuff bursa. Now, the shoulder, of course, is somewhat higher up, but the pain will oftentimes be felt somewhere around the deltoid. If you feel the pain deep within the shoulder, that can sometimes be due to the labrum. And if you feel it in the back, it could be an indication of arthritis. More likely, it can be something like a strain in the rotator cuff or an injury with the labrum. One of the more common things we see with shoulder conditions that can be persistent is night pain. So I always ask my patients, does it bother you at night? If you roll onto it, does it wake you up? If it does, that can be an indication that it's going to be a little bit more bothersome than it would otherwise. Stiffness. When we talk about stiffness, we're talking about perhaps decreased range of motion, as in frozen shoulder, or this sense of creaking, almost like a cogwheel that we see in arthritis. We want to know how long the pain has been going on, because that can sort of give us clues as to what the main problem is. And we also want to assess for apprehension, which is the sense that something bad is going to happen when you put the arm in a certain position. And that typically will refer to instability. Now, the most common form of instability is anterior instability, or where the shoulder comes out the front. And the position of apprehension is this position, where the elbow is out to the side and the arm is externally rotated. That's the position of apprehension typically. There's a cartoon just to depict the shoulder in general. This is a right shoulder. Imagine the patient is facing us. What we see is in red, the muscle. The ball and socket is somewhat hidden behind the rotator cuff, the bicep tendon, and the bursa, which is typically an empty fluid-filled sac, which surrounds the tendons to protect them from abrasion against the surrounding bone. Now, if we want to look at this a little more closely, we look at the figure on the left, and you can see that the rotator cuff is really not one anatomic structure. It's actually 4 muscle tendon units, which combine to envelop the ball and keep it centered on the socket. And based on the lines of action or pull of the muscle and tendon, you can determine what the purpose of that muscle is. So the subscapularis, which sits in the front of the shoulder, is involved primarily in internal rotation, bringing the arm closer to your chest. Opposite to it is the infraspinatus and the teres minor, which are located over here. And these are involved in external rotation. And then there's one muscle and tendon unit on the top called the supraspinatus, which is involved in elevation. Now, elevation is typically when we think of impingement syndrome. So if you look at the cartoon figure on the bottom right, what it sort of is depicting is that elevation of the arm or abduction of the shoulder is causing pain as the tendon and the bursa sac get squeezed between the humerus, which is the arm bone, and the shoulder cap bone, called the acromion. Now we'll just move on to knee conditions that we typically see. The most common things are tendonitis of the quadriceps, which we see typically in middle-aged men. Patellar tendonitis is more common in younger athletes, and hamstring tendonitis is something that we often see in runners. Patellofemoral syndrome is slightly different. That's basically a condition where there's soreness caused by the way the kneecap is rubbing on the thigh bone. That's very, very common. Meniscus injuries, everyone's probably heard of. Knee arthritis is pretty common. And ligament injuries are relatively common. Lower grade sprains of the MCL are pretty frequent. ACL and PCL injuries are thankfully less frequent. Typically, the MCL and the PCL can be treated non-operatively. As you know, ACL injuries sometimes do require surgery, depending on the patient's age and activity level. The things we want to look at when someone comes in presenting with knee problems is where is the pain located? So when it's in the front or they're reporting pain in the back, oftentimes it is something in the patellofemoral compartment or somewhere in the front where the kneecap is rubbing on the thigh bone. When it's on the sides, it can be a variety of things: meniscus, arthritis. Those are the most common things we think about. In the knee, we can often tell if there is swelling, and swelling or fluid in the knee is called an effusion. And that usually is a good indication that something is active in the knee, something acute happened. If the patient is limping, we need to take that into consideration. It may mean a more serious problem. Stiffness or the inability to fully straighten or bend the knee can also be pretty common. And we want to know the chronicity or the duration of the pain. So here, looking at this depiction of the knee, this is a right knee. Imagine the patient is facing us. We see the quadriceps attaching to the top of the patella. The patellar tendon sits along the bottom of the patella and attaches to the tibia or the shin bone. And that's where patellar tendonitis can occur. And then the pes anserine tendonitis is basically where the hamstring tendons insert along the inner portion of the knee. These are just some x-rays depicting what arthritis looks like on an x-ray. In a normal knee, the bones are separated by what's called the joint space. When the joint space narrows, that's an indication that the cartilage is wearing out. And then you can, in the extreme circumstance, develop bone-on-bone arthritis, as you see on the right. What about the elbow? So really the most common things we see are strains and tendonitis. Elbow tendonitis on the outer side of the elbow is typically tennis elbow or lateral epicondylitis. On the inner side of the elbow, this is what we call a golfer's elbow or medial epicondylitis. Strains are when you pull the muscle, and oftentimes people will report strains of the bicep or the tricep. Cubital tunnel syndrome is something distinct. It's basically where the nerve that's running along the funny bone on the inner portion of the elbow is irritated, and that can lead to what we call paresthesias, or numbness and tingling and other sensations that will localize actually to the hand. And we'll go into that in a little bit more detail later. And arthritis is relatively uncommon, thankfully. Again, we're going to look at where is the elbow pain located. Is it in the front? Well, it could be the biceps or forearm. Is it in the back? Especially in pitchers, there's a condition called valgus overload, where the constant snapping of the elbow when you're throwing leads to pain in the back of the elbow. There could also be some element of arthritis. Medial and lateral, or inner and outer, typically is epicondylitis, and then there could also be something called cubital tunnel, as we talked about. Stiffness is pretty common in the elbow. So with elbow injuries or conditions, it's very common to see that people cannot fully straighten the elbow. The bending is really not as bad, but the straightening, if we're really attuned to it, we can see that they're not fully extended. They're probably a few degrees off. Pernicious pain, instability, pretty uncommon, but in the sense, or in the case of, say, the Tommy John ligament, the ulnar collateral ligament, there are tests we can do to look for instability, and then nerve symptoms. Now, I'm sure most people are pretty familiar with some of these principles for injury prevention, but I do want to touch upon them just to review them. In general, you want to warm up, and it's debatable exactly how long the warm-up should be, probably somewhere around 10 minutes, but it depends on the sport. It depends on a variety of things. One of the biggest things I always tell patients is, if you're starting an activity for the first time in a while, you really want to gradually increase both your volume and your intensity. It's very, very common in the beginning to really get inspired, to really be motivated. You want to do so much all at once. And as I like to tell patients, the body will adapt to virtually anything or any stress that it's exposed to if it has a chance to adapt. So that means you got to give it the opportunity to get exposed to the stress, but also to recover from the stress. And we'll touch upon that. Hydration and nutrition, adequate rest and sleep, flexibility and strength training. We'll touch upon that in a few slides. The value of the warm-up is to increase your blood flow, to get cells to the areas where they're needed, to increase the body temperature, because a muscle will contract more forcefully and more safely, typically when the body temperature is increased, and to acquaint the body with the demands of your particular exercise. So if you're cycling, maybe you don't really need to emphasize the upper body as much. But if you're doing something like golf in this picture, for instance, you want to get the shoulders warmed up, you want to warm up the back, you want to warm up the hips, you want to warm up the knees and the ankles. How long you do this depends on your overall conditioning. So typically, if you're just starting out, you might need a longer warm-up. It depends on how demanding the activity is going to be. Maybe if it's very demanding, you need a longer warm-up as well. And it depends on the environment. So if it's a colder day, maybe you need to warm up for a little bit longer. Hydration and nutrition, you could do a whole seminar on this, so I'm just going to do one quick slide, but I think it's really important to hydrate appropriately. Water is probably the most important thing you can drink. I know that we sometimes use things like the sports drinks, but those are probably less valuable than we think they are. About 1 to 2 hours prior to really extensive exercise, I'd probably recommend drinking 16 to 20 ounces, 15 to 30 minutes beforehand, maybe 8 to 16 ounces, about 4 ounces every 15 to 20 minutes. And if you're exercising for more than 60 minutes or participating in a very active sport for more than 60 minutes, you probably should dilute a sports drink to get some of the electrolytes and also to minimize some of the calories from the excess sugar in those drinks. And after exercise, if you are losing a certain amount of water and you weigh yourself and you've lost, say, several pounds, which is not uncommon in, for instance, athletes who are doing spring training, you want to replenish 16 ounces for each pound loss. But you do want to avoid overhydration. Now, nutrition, again, we can spend hours talking about it. You want to have adequate calories, balanced nutrients, consistent meals, and time when you eat certain things like carbs after exercise, but we won't get into that too much. Now, rest, as I look at it, is providing adequate periods of inactivity between sessions, exercise sessions, to really prevent overtraining. And overtraining is something where You might develop signs of fatigue, decreased performance, agitation, and moodiness. If you're really not giving your body enough rest in between exercise sessions, you're doing yourself a disservice. And I really think it's important to sleep 7 to 9 hours if you're an adult. I mean, having good, restful sleep is critical for recovery. And I think that alone will make a big difference in people's performance if they can get on a good sleep schedule. Now, let's talk about strength and flexibility training. What's a good home exercise program for a healthy shoulder? These images are taken from the American Academy of Orthopedic Surgeons. I think they have a pretty good conditioning program for the knee, shoulder, and elbow. And these are some of the stretches you can do to limber up the shoulder and improve some of your rotation. So external rotation is when the arm goes away from the body. This is a door jam type stretch on the left. Forward flexion, you can do that in the supine position, meaning on your back, to try and increase your forward flexion. And then to stretch out the back of the shoulder, you bring your arm across your chest. And you want to try and hold that for 15 to 30 seconds. Now, strengthening can be done using bands or dumbbells. You want to strengthen the shoulder and external rotation with the elbow out to the side. This will emphasize the teres minor and the infraspinatus in that position. And you can also do it with the arm glued to your side, and you can bring the arm out that way, and that will also incorporate some of the posterior delt. And then you can do it, of course, lying on your side using a dumbbell. And you can do this, say, a couple times a week, 2 to 3 sets of 8 or 10. That should help. Internal rotation is basically where you're bringing your arm close to you. Again, you can use the bands or the dumbbells. And it really is important to balance out both internal and external rotation. So in orthopedics, we talk about balancing, coupled motions where you don't want to overemphasize the internal rotation at the expense of the external, or overemphasize the external to the expense of the internal. You want to have it balanced, and that typically will lead to a healthier shoulder. Now, the other thing I do want to touch upon is the importance of the muscles around the shoulder blade, such as the rhomboids, the trapezius, the lats, because we don't emphasize those as much. You don't see too many people at the gym doing exercises that emphasize these muscle groups. And I can tell you firsthand, having seen hundreds of athletes, if not thousands, including overhead athletes like pitchers, that if you want to perform well in an overhead sport in particular, you really need to strengthen the muscles around the shoulder blade, because shoulder motion is not just moving the ball against the socket, it's moving the shoulder blade against your rib cage. And so you want to make sure that there is a harmony there between those coupled motions. So scapular setting is on the left, and this is simply lying on your stomach, just sort of focusing on bringing your shoulder blades together. You can also do something like this using a dumbbell. If you're lying on a table, for instance, you can drop your arm with the weight and then try and emphasize bringing the shoulder blade to the center of your back. And you can see the different motor groups that are involved: the serratus, the rhomboids, the trapezius. So emphasize the rotator cuff and strengthen those muscles equally. You want to emphasize and strengthen the scapular stabilizers. You want good posture, and you want to use caution with repetitive overhead activities. If you start developing some pain doing that, you may need to modify how you're doing those activities or back off a little. What about for the knee? Basic stretches everyone's probably been exposed to. You want to stretch the quad, the hamstring. But the other thing we really want to stretch is the Achilles and the calf muscle. I don't think people spend enough time doing that. Having a limber calf muscle and ankle is really important to preventing forefoot and midfoot problems, as well as Achilles tendonitis. So I really would, if there's one tip I would give, is really work on that as well. Everyone's seen exercises similar to this. Of course, you could do squats, and You may want to start with half squats or just about parallel squats. Going too deep can sometimes lead to pain in the knee, especially in the patellofemoral compartment. Knee extensors, knee extension exercises can be done with the machine at the gym if you have access to one, or you can put weights around your ankle and just straighten your knee as in this figure while you're sitting in a chair. Hamstring curls, really important to emphasize the hamstring. If there's another tip I would give on the strengthening side, it's that the hamstring is typically underdeveloped in most people. And a strong hamstring, by the way, can be protective of your ACL. Calf raises are important as well. Pretty self-evident how to do it, although you can also do it, say, where you drop your heel off a step to get some extra stretch. The other tip I would give people is the core and the hip is very, very important. And working on your hip flexors as well as the abductors, or the muscles that bring your leg out to the side, is really something, again, that's probably underemphasized by a lot of people at the gym or in their training. So doing things like straight leg raises and side leg raises can be really, really beneficial. So emphasize the quadriceps and the hamstrings and really try and focus on balancing those muscle groups. The hamstrings are not going to be as strong as your quadricep by their very nature, but you need to really strengthen those hamstrings to prevent ACL injuries and to improve things like sprinting, etc. So I really would emphasize the hamstrings. Your core, that means your low back, your abs, and the hip muscles are also muscle groups that I think should be focused on. Good posture, and just be careful in the beginning, especially with excessive impact activities. That means running, jumping, sports. Elbow stretches. If the elbow's acting up, you can do things like this, which try to stretch the muscles of the forearm, which are involved, say, in golfer's elbow and tennis elbow. Basically, you straighten your elbow, use the other hand to extend the wrist, hold it for a certain amount of time, relax. You can do the opposite. And then you can take a soup can or some dumbbells, start with, say, a 1 pound dumbbell, do your wrist extensions, your wrist flexion, and also work on rotation of the forearm. We call that supination and pronation. Now, when should you contact the MD or see someone like me? Now, a lot of these things, oftentimes, you can treat by modifying what you do, trying some Tylenol, ice, or maybe something like Aleve for a period of a couple of weeks and see how you respond. But if you develop acute severe pain, you can't move your arm, could be a rotator cuff tear, could be something else called calcific tendonitis, you may want to see us. If there's an acute trauma, obviously you want to have that evaluated. A fracture or sprain is something that should probably be seen, obviously. A sprain of the AC joint or a separated shoulder, typically, that gets treated non-op, but you still want to have it evaluated so that you know what's going on and you can get treated appropriately, say with a sling or whatever it is. A dislocation or instability is also something where you want to have someone evaluate you, because instability in and of itself, of course, it's damaging to the ligaments, but repeat events typically will lead to further damage to the labrum, the ligaments, and the cartilage, and that damage can sometimes be irreparable. So you want to get that evaluated. Mild, moderate pain that is not improved with Tylenol, the anti-inflammatories, ice or heat, modifying activities after a couple of weeks, maybe then you should come in, have it evaluated. In the knee, the principles are pretty similar. If you have acute severe pain, then you may want to come in. Could be an arthritic flare-up, could be a ligament injury that you just developed or a meniscus tear. If you develop a significant new limp, you should definitely get evaluated. If you develop acute swelling in the knee that you've never experienced before or that's unexplained, you probably should get evaluated. Mechanical symptoms, that means locking and catching. You can't straighten the knee, or you feel like something is getting caught in the knee, then you should come and see me. And same principles, if you have mild, moderate pain that's just not improving, despite conservative treatment, modifying your activities, icing, doing the Tylenol and the anti-inflammatories as directed, of course. Look at the box, look at the directions, then come in and see us. So I want to thank everyone. And of course, I'll leave it open to questions. I encourage everyone to visit our locations, whether in Harrison, if you're in Westchester, or Greenwich location, or Stamford. So we have some questions here, and we'll touch upon, someone asked, what is overhydration? What problems does it cause? Ironically, and I'm certainly not a triathlete or an expert on triathlons or ultramarathoning, but overhydration is when you actually imbibe or drink too much fluid, and you can become hyponatremic. Basically, that's where you develop a serious salt imbalance in your body, and that can be devastating. That's probably worse than dehydration in some cases. So what I would encourage is, be sensible. Don't drink to excess. You don't need to drink a gallon of water right after you finish the event. But you do need to rehydrate with water, especially if it's a hot, sunny day, because certainly with some of the football players, when at the training camps, at the college or professional level, some of these players can lose 20 pounds of body mass, typically water weight, with a training session. So they need to rehydrate. One tip I would say, if you're underhydrated, if you look at your urine color and it's a dark amber, then you really need fluid. If it's clear, then you should back off. You probably have enough fluid. Interesting question. Sometimes I get asked, what are the foods or supplements that can be helpful in keeping joints healthy? I think that clearly there's a lot out there in the media and in the literature. It seems very wishy-washy to simply say a balanced, nutrient-rich diet is the best way to go. There's a lot of debate as to whether you should be paleo, keto, high carb, low carb, what are the macronutrient profiles, etc. I think whole foods are obviously better than processed foods. I'd stay away from the processed foods. In terms of supplements, chondroitin and glucosamine are obviously supplements that had a lot of airtime maybe about 10 years ago. The data on chondroitin and glucosamine is limited, and they probably do not work as effectively as we anticipated. So at this point, in general, they're not recommended. In terms of other supplements, besides just making sure that you're taking the appropriate vitamins and minerals, there really are no specific things that we in the orthopedic community necessarily recommend, because nothing has been proven medically to provide a significant benefit in people who are already receiving adequate amounts. So a lot of people will experiment with things like zinc, magnesium, whatever it is, but I think that that's probably a little bit overdone. Someone asked about golfer's elbow. Will icing still help if it's been ongoing for a while? There's no doubt these tendonitis conditions will persist. You have to be prepared that elbow tendonitis, meaning golfer's elbow, tennis elbow, is a condition that no matter what does not typically go away overnight. It typically takes weeks, if not months. You have to be prepared for that. I think icing after activities might be helpful. Certainly you don't have to ice every single day, but after activities that might help. Someone asked, what is the difference between a labrum problem and biceps tendonitis in the shoulder? Can you tell? Sometimes it's not always very, very easy. So a labrum problem due to instability is typically much more easily suspected than a labrum injury, namely a slap tear in an adult who also has pain in the front of the shoulder. oftentimes you will need to get an MRI. Our physical exam tests are not that specific, meaning they might be able to pick up a problem, but they can't tell you exactly what the nature of that problem is. So what can you do for arthritis besides medication? Oftentimes for arthritis, what I will recommend is modalities, what we call modalities, ice or heat, may give you some temporary relief. You can try a neoprene sleeve or a knee sleeve. I think the data is very clear that a strength and conditioning and flexibility program will improve the symptoms of arthritis. That's been shown over and over. Now, you do have to maintain that program, but that is probably the best thing you could do, is maintaining strength, flexibility, and conditioning, and maintaining a good body weight. That's your best bet against arthritis. So I appreciate everyone participating. I encourage everyone to seek out our experts, whether it's shoulder, elbow, and knee in my case, or other experts, because we cover everything head to toe. So if you need a foot and ankle expert, a hand and wrist expert, I would encourage you to check out our website at onsmd.com and visit one of our locations, whether in Greenwich, Stamford, or in Harrison. We provide one-stop service for all your needs, not just seeing a doctor, but physical therapy, imaging, including x-rays, and we have MRIs at multiple sites. So I appreciate your time.